και πότε Αλέξανδρα παρέμεινε online. Αλλά πριν να φύγουμε, να προχωρήσουμε, can I ask if Professor Cecchi, McKenna, Thiene are online? Είναι συνδεδεμένοι ο Cecchi, McKenna και Thiene?
Professor Cecchi seems to be.
Yes, online. I'm online.
Oh,
Hello.
okay. Gaetano, excellent. Okay. Franco, sorry. Franco. You heard the overview of the guidelines, the new guidelines.
Yes, I heard part of it because they didn't connect me before, but I know the guidelines.
Okay, good. Stay online because we'll continue with Professor Antonis Pantazis from Brompton, and then we open the discussion about on the guidelines. Okay?
Okay, great.
All right. Okay, Adonis. Now you can speak in English, Adonis.
Yeah, no problem. Thank you. I'll share my screen only to show you one slide, which is this, which I think is important for some aspects of the discussion later. These are my declarations of interest for the purpose of the guidelines, but you might have seen that authors of the guidelines have a much longer list of declarations of interest, and this is something that we may want to discuss later on. And I don't have any other slides, because what I'm planning to do is discuss with you my views, some views on the guidelines, and I hope that will initiate discussion. So the guideline project was a huge one and an amazing one, and enormous effort has been put into this, and I have to congratulate also publicly Alex, who was actually one of the hardest workers in this task force. However, outside the work that has been put for this particular guideline, I wonder if this is still the right way of doing things. Because you can go from Athens to Thessaloniki walking, and it can take a few days, and you can put a huge effort in, but is this the right way to commute from Athens to Thessaloniki? Maybe there are better ways to do that. Or maybe you need to stop halfway in Lamia and then continue to Larissa and then continue to Thessaloniki and break the whole thing into smaller areas. So it's a question to all of us whether the methodology of the guidelines, not just these particular guidelines, but the guidelines altogether, is still valid in the current era. And what are the metrics to evaluate the outcome? So are we looking at the right metrics to evaluate the outcome of the guidelines we produce, European Society of Cardiology produces? In my opinion, the best metric would be the changes of practice which are facilitated or supported by the guidelines. But do we really have any mechanism to capture the changes of practice? Can we audit in any possible way the changes of practice in different countries? Do we know how applicable the guidelines are in different countries? Another important point, and Bill has kind of stolen my thunder earlier, but obviously he's allowed to do that because I have learned to think outside the box from Bill, is the discrepancy between European and American guidelines. If we all look at the same data, if we all look at the same science, why should there be such a huge discrepancy between American, European, and possibly other guidelines? It makes me think, but I don't want to be suspicious, that there is a political reason behind that. And by political, I don't mean driven by governments, but I mean that there are agendas from the individual societies or individual scientists which drive guidelines on either side of the Atlantic, and maybe these scientific documents are not as transparent as they should be. And also Bill made another point, which I was planning to raise as well, but he actually did it very well. He mentioned that in the American task force, there were all people from the Mayo Clinic and so on, which I think it's a universal issue with the task forces for guidelines. The guideline task force members are chosen based on a mixture of scientific and non-scientific criteria maybe, and this process may need to change. And interestingly, whilst these current guidelines for the cardiomyopathies were in production, the process of choosing the task force members within the European Society of Cardiology has changed. I may feel a little bit flattered to think that that was partially because of some probably intense discussions that I had with the ESC executives, but probably it wasn't me. It was probably other people who have also complained that the selection of people for task force members wasn't as objective, as transparent as it should be. And the transparency is very important for scientific documents. And this is why I only showed one slide which included my declarations of interest. It has to be entirely transparent where every single member of the guidelines task force comes from and what possible influences they may have. Lobbying is probably inherent in the human nature. So we will not skip that, whatever, we will not prevent that, whatever we do. But there are now new things coming in, which are also a risk for member selection. And these include political correctness, and unfortunately, and very disappointingly, tokenism. And by tokenism, I mean that we now discuss left and right that patients should be involved and included. But have we actually thought what the patient participation in a task force means? Do they have an active role in the task force? Are they able to contribute an opinion which will be important for the decision making? Or do we have a patient there just to say that we have a patient there? And this is even more dramatic than not having a patient there. And this, I will come back to this when we discuss the very valid point of the shared decision making. The new guidelines, the cardiomyopathy guidelines, to come back to the cardiomyopathy guidelines, because what I have said so far is probably more general and it doesn't necessarily apply exclusively to the cardiomyopathy guidelines. But the new cardiomyopathy guidelines have introduced some new concepts which are very important, and Alex has gone through them, so I will not repeat any of those. Just to mention that the concept of the integrated care, of the patient's pathways, of the multidisciplinary care are very important to discuss, as well as the involvement of genetic testing in cardiomyopathy, because they are in principle genetic diseases, how genetic testing should be integrated within the clinical management, and also the thresholds for making decisions, and we need to move away from the absolute thresholds of 5%, 6%, 20%, and someone who has a 19% risk is safe, but if your risk goes up to 21%, then you are unsafe. These thresholds are not scientific, are not clinical, and we need to move away from these thresholds. Now, this is quite relevant also to the shared decision-making process, which Alex has mentioned, and I think is extremely important. But let's think of a very simple situation where we take our car to the workshop and we are told that we need to replace something in the car because it doesn't work very well. How much knowledge do we have about how the car works, and how much influence can we have in this decision making if we are not told all the information? So I think that in order to have responsible shared decision making, we need to have educated patients. So this starts a huge process of making the patients partners in the whole pathway, rather than ask them at the very last minute, do you actually want an ICD or not? I think it's good for you. What can the poor patient say? No, I don't want one. Or if we go the other way and say, I don't think an ICD is good for you. Do you really want one? The patient will probably say, oh, no, doctor, I agree with you. I don't want one. So shared decision making is actually not an instant, is a whole pathway, it's a whole process which has to start from the diagnosis and has to follow the relationship between the doctor and the patient all the way through. And this is only the only chance to make the patients proper partners in this decision. Now, coming to some individual details of the guidelines, there has been some possibly this discussion, let's put it this way, about a number of points in the guidelines, including the definition. Alex mentioned a couple of times the ARVC, but we had a session yesterday where I made my view public that ARVC cannot be called ARVC anymore because, you know, it's biventricular. Why should we pretend that it's only right ventricular? And why should we separate the left ventricular from the right ventricular in a way that doesn't make clinical sense anymore? However, the guideline was not the right place to discuss that, and rightly so, didn't make any new recommendations on the subject. However, it is a weakness of any guideline if the starting point does not have clear definitions. So with some of the cardiomyopathy definitions being fluid, obviously the guidelines would have an inherent limitation to produce very robust guidance. And also the new term of non-dilated left ventricular cardiomyopathy, it's called cardiomyopathy. In the definition, the acronym includes the word cardiomyopathy, so we cannot pretend that we are just describing a phenotype. The phenotype is what we used to call early phenotype, pre-phenotypic stages, which is a known concept to us. I mean, that was published by Philip Sharon, I can't even remember how many years ago. I usually say 5, but I think it's longer than 10 now. But Philip published the pre-phenotypic expression of dilated cardiomyopathy, and he did acknowledge in that ESC paper very rightly that we have very little information, very little evidence on that. And I'm afraid that the evidence is still very little. So it's very important to acknowledge that, but not to acknowledge it maybe as a separate type of cardiomyopathy, but as a phenotype. But if we use the word cardiomyopathy in its own definition, then we call it a cardiomyopathy, and it may be confusing for people who read the guidelines in Asia, in Europe, and everywhere else. And why don't we then acknowledge the non-hypertrophied hypertrophic cardiomyopathy? It's also an entity, hypertrophic cardiomyopathy with minimal hypertrophy, which does not meet the criteria for the diagnosis. Why do we only recognize the non-dilated left ventricular cardiomyopathy? So you understand that these are limitations that the guideline paper was probably not able to address, maybe shouldn't have gone there anyway. Now, the other issue related to the guidelines is the resources. We typically don't look at the resources that are required to implement the new guidance. One can argue that we shouldn't care too much about the resources. What we need to publish through the guideline documents is the good science. And whether, for example, an MRI scan is needed every year or every whenever, and this is the recommendation, and then the local healthcare systems need to sort out the resources. But the resources are a huge issue because the resources are very relevant to the implementation. One thing is to suggest something, and another thing is to make it happen. For example, I know from my work with Italian colleagues that the hospitals are reimbursed for the echocardiograms they do. So increasing the activity through increased diagnostic test frequency of the diagnostic test is actually a good thing for the hospital. In the UK, it used to be similar until a few years ago, and now it's the opposite. We are penalized if we have a large number of echocardiograms waiting to be done, and if we have long waiting lists and so on. So we cannot implement the same guidelines. And the guidelines in this sense are a burden, because if they say, for example, that you need to do an MRI or an echocardiogram every year and it doesn't happen, they sometimes have the value of a medical legal document. And if the medical legal document suggests that you have to do it, then you might be found, to practice in an inappropriate way. It might be malpractice not to do it. And therefore, the guideline may not work in the favor of the healthcare professionals. Now, coming to the last part of my comment, I think it has been acknowledged by everyone, and Alex did mention it very nicely with a figure in his presentation, that we don't have enough data to publish strong guidelines based on evidence. Most of the recommendations are class C, and this will probably remain so until we change the way we practice probably everywhere, but in cardiomyopathy more particularly. It is very interesting that the limitation area of the guidelines has been read by a lot of colleagues who then fed back to us, to me and to other people that, oh, that's so interesting to see all these limitations, because in the limitation area of the guidelines, we actually acknowledge in a very humble way what we don't know, and there are a lot of things that we don't know, and probably the list is even longer than what is published. And also the algorithms which are used now left and right are probably the right way to approach things, but they are not good in producing recommendations based on precise recommendations, because the data behind the algorithm is not so strong. And if we don't have strong data behind the algorithm, it's like a small exercise of artificial intelligence. If we teach the algorithm to produce some outcomes, but we don't use good quality and good volume data to set up the algorithm, then the algorithm will not produce good recommendations. And therefore, the widespread use of the algorithm has some pitfalls which need to be very widely recognized. For example, in the hypertrophic cardiomyopathy algorithm, if patients with apical hypertrophic cardiomyopathy are not well represented, then they shouldn't be, the algorithm shouldn't be used for these patients. So we need big data and good data, but it's sad, and maybe Petros has an opinion on that, it's sad that the EORP has actually been shut down within the European Society of Cardiology. The EORP was the part of European Society of Cardiology that was looking after registries, was responsible to set up registries, and this is disappointing because it means that we are not moving as a big organization in the direction of setting up big registries with a lot of data. Setting up regional registries is almost a competitive exercise. At the end, it may work in the benefit of everyone, but it's not a good starting point not to have big registries. And for example, in the UK, we have a national registry now for genetics, which works much better than having multiple labs producing their own results without any discussion or competition between them. And finally, I think that what we would need, possibly together with the guidelines, or maybe, or even to replace at some point the guidelines, is meta-analysis. Meta-analysis in everything we are discussing is not good enough to take the outcome of a publication and use it without looking at the data. We need to look at the actual data which are behind every publication, and if possible, to look at the data that have led to this publication, and this is how we can move forward. This is the first step for artificial intelligence, which we keep referring to it, but if we don't do work at the level of the data, of the original data, then we'll never have artificial intelligence. I know that meta-analysis is a very, full of effort and time and expensive exercise to do. However, that's the only way to actually approach the subject. So maybe I was critical, but that was my role today, to be critical. I think that the guidelines are an opportunity to increase awareness, to spread the word, and possibly support some practices around the world in the field of cardiomyopathy. Also to introduce new concepts, but maybe the future will not use guidelines for this purpose. We'll use different tools which are based more on technology and original data, and which will be more transparent and reliable. Thank you.
Thank you. Thank you, Andonis. That was a very, very good, very precise assessment of the guidelines. These issues have been going on and on for many years. There are agendas, individual agendas, and career structuring individuals who take part in the guidelines. I have personal views on the heart failure and the previous cardiomyopathy guidelines, and we had long discussions and arguments amongst ourselves about what to put and what not to put. Very, very difficult, but they are useful. I have personally used the guidelines to put pressure to the administration at the Hammersmith Hospital in order to change some of the practices the administrators wanted to implement for the reasons you quite nicely mentioned. So they have a use. Guidelines are guidelines and no laws, but you mentioned very clearly that they do have a use. I would like to take the view of Professor Cecchi now, who is obviously actively involved in Europe and beyond. We have about 7 minutes, Franco. You have 2 or 3 minutes to highlight your points, and we can ask maybe Professor McKenna, who is now in the audience, to have a brief comment. Bill, you need 60 seconds comments. Franco.
Well, I will start from the one of the points that Anthony beautifully exposed before, the fact that the shared decision making. I find this in my practice something that I've always been doing. The problem is, as he mentioned, the fact that the patients usually are not aware of what we are talking about. So it's not really a shared decision. I mean. So let me just say, probably even last year I mentioned that we decided together with Jacopo Olivotto and many other doctors and patients to start a new society, an association of patients for cardiomyopathy. It's called ICARM, and we've got really a big success. We have, and we make courses. We make courses for patients to educate patients. And these courses have been held in Florence, Milan, Rome, and it's a little bit cumbersome, but it's really very successful, and we're very happy with that. So first of all, that's an issue that all cardiology would take care in this sense, because our decisions sometimes are just based on our experience, on the guidelines, but above all, on what are the preferences of the patients. And this is very important, to learn how to discuss with the patients. So this is my first message. And this is, I show one of the slides which has not been shown today, but usually in my talks now, my last slide is about this. One of the big important messages of these new guidelines was that you need multidisciplinary centers, you need patient advocacy inserted, and you have, of course, experts in cardiomyopathies, to really deliver the good, the appropriate therapies to these patients. So this is one issue. The other, and I don't know if you have them in Greece, but I mean, I would really suggest you to create one, and we're ready to help you in this sense. We are part, by the way, of an international network, but I haven't seen Greece there. I've seen, Cardiomyopathy Association from UK, from Australia, from US, Holland, Germany, and so others. So that's my message for you this morning in this sense, okay? Try to create one even in Greece. The second point is about the whole issue. I mean, I believe that these new guidelines finally showed to all cardiologists that cardiomyopathies exist, that hereditary heart muscle diseases exist, and they have to take care of them. So don't just think anytime you find a T-wave inversion to coronary artery disease and do immediately a coronary arteriography, but try to understand if there is another kind of disease that is responsible for that. Of course, they're not perfect. There are several issues which should be discussed and have been clearly discussed by Anthony before. Above all, the most critical, there are two, is about the arrhythmogenic cardiomyopathy, and I don't want to repeat what he said before. Of course, I don't know why the Padua criteria were not fully reported. However, I mean, that's where we are. So people have now to understand that they should really clearly move forward and try to understand why you have some kinds of arrhythmias, and then to understand what kind of a disease is on the background. The problem is the resources. The resources are very limited, even in expert centers. I mean, we in Florence, maybe we are now having, under the direction of Jacopo Olivotto, maybe the center that sees most patients in Italy. We have patients even coming from abroad, but the problem is where are the funding? And if the funding only comes from research and from, above all, from drug companies or other kinds of companies, then you are in a way biased in a way, and you have really to be very, very careful not to be biased, as Anthony pointed out. The other point is about the resources for gene analysis, for MRI, and we don't have any problem with echo, but MRI is a critical problem. So that's another issue. And also about therapy. I mean, in Europe, we are not homogeneous. I mean, we have patients that, would need an ICD, and if they live in Romania or Albania or other countries where this is not free, then they cannot have this kind of resource. So I believe that the European Society of Cardiology should take care of that, and also should take care of the fact that they should create a network in Europe, above all, and to collect data, as you mentioned before. So we need data in order to understand, if things are really proceeding in the right direction. And there might be some wrong direction, of course, as there have been in the past for ICD interventions, or deciding where, SRT would be septal alcohol ablation or myectomy. So this is also, again, one more issue. Where are the centers that can reliably treat these patients in Europe? Is there a standard? I mean, is there been recognized centers for that? In the US, it's easier in a way. They do it by themselves. But I mean, we haven't really addressed this issue. And I think these are all important points that I would just limit my discussion to these ones that I have mentioned. And I want to hear what Bill, as one of the greatest experts in this field, I mean, practicing for over 50 years at this point.
Okay. Franco, thank you very much. Before Bill, I want to ask Aris Anastasakis to have a comment. Use the microphone, please. Aris, then Bill, and we'll wrap up.
Thank you very much. I think that this guidelines created a huge discussion because of the fact that arrhythmogenic cardiomyopathy was not one of the cardiomyopathies that was classified originally. And I think this is normal because, for example, we know that arrhythmogenic cardiomyopathy has many phenotypes. It has the phenotype of the right heart disease, the phenotype of DCM, and both ventricles affected, and the phenotype of the left ventricle. The question is, the phenotype of the left ventricle cardiomyopathy is only arrhythmogenic cardiomyopathy? I think it's not. There are many genes that they can have a clinical expression of a preserved ejection fraction, fibrosis, and arrhythmogenicity that we cannot put them in the spectrum of arrhythmogenic cardiomyopathy. So for me, it's not exactly right that we have only one form of cardiomyopathy, arrhythmogenic right cardiomyopathy, but I don't think that we have any other choice. So it's important to know that arrhythmogenic cardiomyopathy is a disease with 3 phenotypes, at least. But at the same time, we must realize that if we classify it according to the morphology, it's normal to have limitations. The disease is not the morphology. So maybe in the future, when we are going to classify according to the genetic substrate, then we can be more near to the truth picture, to the truth. But at the moment, I think we have to stick with these limitations and to agree that the new guidelines add something more in our work and in the way that we treat the patients. For example, apart from the arrhythmogenic cardiomyopathy issue, we solved the morphology of trabeculation. We know now that trabeculation is not necessarily a cardiomyopathy, and also with subtypes of cardiomyopathy like the Takotsubo, I think the picture is much more clear. And I want to finish my comment with a question that what's the future of this treatment, mavacamten, and if we're going to apply it to implement it in non-obstructive forms of hypertrophic cardiomyopathy.
Thank you, Aris. So please, we will not discuss treatment at this point. That's another session over coffee. Bill, 60 seconds, last wise comments.
Timer's on. So you started the discussion. I'll go back to what you said about the guidelines. Guidelines are guidelines. They're not laws. And you need to look at them critically. And in America, you have to follow the guidelines, because if you don't and something happens, you go to court. In Europe, we have the luxury of doing what we think is best for our patient, and there are guidelines to help us. But you rarely get hauled up before the legal processes because we didn't put in the ICD or we didn't do this test or that test. But just one example, if you go back to not the Almond guidelines, but the American guidelines, the one before, look critically at where the guidelines are coming from. There were 5 individuals from one institution, another that was essentially from that institution, and 2 from the Harvard group, okay? And the European guidelines there were 14 people, and there were 9 experts from different countries with different perspectives. The perspective of what is effectively a private company, a hospital, is very different than the perspective that we will have as physicians mostly representing or working within public systems. And the recommendations reflect those things. So they reflect doing an ICD, having an EP study, having CMR, and doing operations, as opposed to things that don't make money, like doing a gene test. That's in brief. The second thing is Antonis made a comment about meta-analysis, and it indirectly, Franco was also on the same wavelength of we need more data. We can't single center, small registry data is not adequate. We need big data, and we have the capacity. So there's various ways of doing this, but we, as a cardiological community, we have to lobby the companies, the governments to get big data, because we're making decisions based on inadequate data. So meta-analysis, one example, Antonis was going on about it. In general, if you have enough literature, the dust comes out, settles. But for instance, if you do CMR and you look at the meta-analysis for late gadolinium and HOCM as a risk factor, there's 2 major studies that dominate this. And both studies are good, but one study is a very detailed study of MRI, late GAD, but there's no risk stratification. So nobody has an exercise test, and it's very unclear whether somebody had a Holter. But in this study, 18 people died suddenly with no risk factors. Well, that just doesn't happen. They didn't have risk factors because they didn't do the risk stratification. And this paper gets mindlessly, it influences every meta-analysis. So the meta-analysis says, oh yes, late GAD 15%, very important as a risk factor. It's not important it doesn't happen in isolation. It happens in association with other risk factors, which are actually simpler and easier to do. And I don't think we still have the right characterization in relation to the risk factors in terms of late gadolinium. With respect to the classifications, I think you have to be critical. There have been different attempts, but if you go back over time, don't throw the baby out with the bathwater. We've had the same HCM, DCM, then ARVC, RCM. Okay, ACM is ACM, arrhythmogenic cardiomyopathy. Is it really DCM with a heart failure, DCM with arrhythmia? You can play games, and it comes down to vested interest of individuals. But the dust eventually settles, and there was an American attempt at ACC-AHA to put together a scientific classification based on genetics. And it was brave and noble, but it failed because it's not a gene, it's not a myosin-binding protein 3 that comes through the door. It's a patient with a symptom, a sign, a family background, an abnormal ECG. It's not a mutation. So having a clinically oriented classification that isn't oriented around the phenotype, around the patient, will not work. It may work if you're a mouse doctor, which mutations and which knockouts you're doing, but it doesn't work clinically. But the dust settles on these things. So there's a degree of outrage about the current European guidelines, which have changed the nomenclature a little bit, but they're actually very comprehensive and very, very good, as we've seen. There's minor things, and the dust will settle, and the Padova experience was not properly incorporated into that has already been mentioned. That's my minute.
Okay, thanks, Bill. You kept the time. So we'll break the session now. Παρακαλώ, θα...
Petros, one single comment, only 10 seconds, but real 10 seconds, not with
Okay,
timer. So my comment is that the classification of the cardiomyopathy may be a different task for a different group of people, for a different setting, rather than the guidelines. And maybe that will help us, not put everything together in one document, to try to reclassify cardiomyopathies and then at the same time produce practical guidelines. If we separate the two, maybe it will be better, because I totally agree with Aris about the overlaps and Bill and everyone else about the overlaps, but this is probably something that should not be discussed in the practical guidelines.
We need a think tank. Okay, wise comments. Λοιπόν, ας σταματήσουμε εδώ. Ο πρόεδρος μου είπε 15 λεπτά για καφέ και μετά να συνεχίσουμε για να μην χάσουμε την μπάλα από το πρωί, γιατί αλλιώς πάμε μεσάνυχτα. Λοιπόν, παρά 10, όλοι εδώ να ξεκινήσουμε.